Afternoon. I'm Dr. Kathleen Brady from the Philadelphia Department of Public Health and the Penn CFAR. On behalf of my co-moderator, Dave Metzger of the UPenn CFAR, and this session's panelists, I want to welcome you to this session on engaging key populations mid-Atlantic HIV epidemic edition. As we know, HIV, racial ethnic minorities, MSM and transgender women, PWID, and youth have high incidence and prevalence of HIV. Engaging people in these priority populations in the HIV prevention and care continuum is essential to ending the HIV epidemic, which is why we're talking about this important topic today. Before we begin, I ask the audience members to put their comments and questions in the Q&A tab as the talks progress. Please include who the question is directed to when you ask your questions. And as a reminder, there'll be a Q&A and roundtable discussion at the end, so please stay with us through all the talks. So with that, I'd like to introduce our speakers today. We will have Daiquiri Robinson from the Penn CFAR CAB, Amanda Castel from George Washington University, Sarah Wood from the UPenn CFAR, Omar Martinez from Temple University, and Sarah Calabrese from the DC CFAR. And so with that, we can begin.
Good afternoon. My name is Daiquiri Robinson, and I am the chair of the Penn CFAR CAB. And the topic that I'll be sharing with you today is the reach of the CAB, engaging community. Our objectives are to explore what is your definition of community? Who are your stakeholders? What does an honest discussion with the community look like around research? What is the mission of your community advisory board? And how does community engagement benefit you? The first question we need to ask is, what is your definition of community? It's important to create a clear definition of who your community is. Who do you want to sit around the table and represent your community advisory board? Engage varying parts of the community for your board. And that can range from business owners, churches, to people living with HIV. Also, reach out to find those community members who have a passion for the work. Because if they don't have a passion for working in HIV, then the community board will not move far in helping you to get your research information out. Who are your stakeholders? Build a coalition of stakeholders who will support your work and gain their trust. This is a very important step because you have those folks in the community who really are the ones, the leaders, the activists, who really want to see good things happen in their community and will let you in if you talk to them. They are the gatekeepers to everything that the community holds. And this is a good time for you to learn more about them and make them feel valued and needed, because their life experience is an asset to any community board that you are willing to put them on. Have you ever had a discussion with your community on your research? It's very important to understand that many communities that you will come across do not trust researchers, they do not trust doctors. And one of the main complaints they have is that researchers come to our community, we let them in, we give them all of our information, then they leave and they never return with the results. But I want to say to you, just be able to handle questions and concerns from the community that may be very uncomfortable. And make sure you tell them, what is it about you as a researcher that would endear the community to want to help you in your research? And acknowledge those issues and concerns. Do not take them personal. Just answer the questions and let them know that, yes, in research, some things did not go right, but let them know how you and your staff are different. Think about the mission of your community advisory board. What is it that you want them to do to help to drive your research forward? Let's take a look at Penn's mission. Our mission is to foster and maintain partnerships and open communication among community members and HIV researchers, and to enhance HIV education, prevention, and treatment research activities reflecting both the needs and interests of the community and Penn investigators. Let's just take a look at what we said we were going to do. We're going to foster and maintain partnerships. That means we're going to be partners. There is no power struggle here because the community brings its own unique talents to a community advisory board. And you, as researchers, you bring your brilliance and talents as far as research and HIV is concerned. So together, as a partner, you can do wonderful work. Open communication. Open communication is key because it is essential that the community, when they ask questions, that they get answers. If you try to hide things from the community, then they don't trust you, and then they don't want to work with you. So it's always great to have open communication. And it's okay to say, I'm doing research, but I don't know where it's going to lead. This is what I hope it will lead to, but we just don't know until the research is done. Look at enhancing HIV education and prevention and treatment research activities. It's okay to teach your community advisory board how to read a research protocol. It's okay to let them know what the IRB is, as well as informed consent. Give them the knowledge that they need so they can help you drive your research forward. And this essentially is what we call community engagement. Now, the Center for Disease Control defines community engagement as the process of working collaboratively with and through groups of people affiliated by geographic proximity, special interests, and or similar situations to address issues affecting the well-being of those people. And that's what you are. That's what you continue to do. The benefit of the community will produce for you not only fruitful projects, but discussions around important issues in the world of HIV research. You all can give suggestions to the community. They can latch onto it, but it's important to make sure that they understand what it is and teach them. It's okay to teach the community advisory board science because even though they may not understand every part of it, you give them what you're trying to do in research and they will truly understand. Get them excited about research. Let them know that research is for them and let them take it out to the community. Your engagement will expand your reach in the community where expertise abounds. You have nothing to lose. The only thing you have to lose is being afraid of the community. The community is willing to help you. The community is willing to be there, and the community is willing to drive everything you do forward if you only give them a chance. So for that, I say thank you so very much for listening, and I hope that community becomes a major part of your work. Thank you.
Good afternoon. I'm Amanda Castel. I'm a professor in the Department of Epidemiology at George Washington University and the lead of the DC CFAR Ending the HIV Epidemic Scientific Working Group. In the next few minutes, I'll be providing you with a high-level overview of the epidemiology of HIV in the Mid-Atlantic region of the US, with an emphasis on 3 key cities: Washington, DC, Baltimore, Maryland, and Philadelphia, Pennsylvania. As we all know, the HIV epidemic in the US tends to be concentrated in certain geographic areas, with many diagnoses occurring in densely populated urban areas. Washington, Baltimore, and Philadelphia are 3 urban areas that have extremely high HIV diagnosis rates, ranging from 788 to 2,361 people per 100,000 population. And all of these cities are focus jurisdictions for the Ending the HIV Epidemic, as shown on this map. While the cities each have high HIV prevalence rates, they also share other similarities. As you can see here, the populations range from about 593,000 to 1.5 million, have diversity with respect to the percentage of their residents that are Black or Latino, and have high proportions of people who have completed high school. And yet the median household income is as low as $45,000 in Philadelphia. 14 to 26% of the city's residents are living in poverty, and 4 to 9% of these cities' residents are uninsured. You can also see that each city has been faced with large numbers of COVID-19 cases and deaths. And importantly, while there are many demographic similarities, each city is distinct and has its own local culture. If we compare new HIV diagnoses by city over the last decade or so, we see that in 2007, all 3 cities identified more than 1,000 new diagnoses. Since then, significant declines have been observed across the board, with Washington, Baltimore, and Philadelphia reporting 282, 353, and 439 new diagnoses each, respectively, in 2019. If we further stratify these new diagnoses by demographics and mode of transmission, we can see that the largest proportion of new diagnoses were among the 20 to 29-year-old age group, that most diagnoses were attributed to male sexual contact, and that the majority of diagnoses were among persons identifying as Black. If we drill down even further, we start to see distinct features in each city's epidemiology. This table is from an analysis that was conducted across the 3 cities in 2017, which compared national HIV behavioral surveillance data for the men who have sex with men cycle. This analysis found that there was high HIV prevalence among MSM in each city and extremely high rates of previously unrecognized infection, with as many as 69% of MSM in Baltimore being unaware of their infection prior to getting tested for HIV. When looking specifically at the prevalence among Black MSM, similar observations were found, with almost 40% of Black MSM testing positive and 74% of them having unrecognized infection in Baltimore. Other analyses not shown here provided additional insight into city-specific drivers of the epidemic among this particular high-risk group. With respect to the care continuum, each city is making progress along the various stages. Compared to the United States as a whole, Baltimore had a slightly lower proportion of people who'd been diagnosed with HIV, but all cities were at or above the overall US proportion of people linked to care and retained in care, with Philadelphia lagging slightly behind the other 2 cities with respect to retention and care. Finally, all 3 cities had higher viral suppression rates compared to the national average, ranging from 67 to 69%. Using PrEP as one indicator of HIV prevention, you can see here that 14 to 44% of people in each city were prescribed PrEP, which is below the national EHE goal of having 50% of those who can benefit from PrEP take it. So given these epidemiologic profiles, how are the 3 cities addressing their ending the HIV epidemic priorities? Well, each city has developed its own EHE plans and goals and tailored them to their local context. An in-depth review of each jurisdiction's EHE plans finds overlap in their approaches, ranging from technology-based interventions to rapid ART to home-based HIV and STI testing and rapid outbreak detection using molecular HIV surveillance. Importantly, all 3 cities have been intentional in seeking out community input and engagement in the development of their plans and have also established academic public health partnerships to help further support these efforts. I'm now going to highlight a few examples of local and regional EHE approaches being taken. From a research standpoint, the 3 CFARs in these cities have created an inter-CFAR program called the Mid-Atlantic CFAR Consortium, or MAC. This program is designed to support underrepresented scientists and research to address the HIV epidemic in the Mid-Atlantic region and provides resources for scholarship as well as cross-institutional mentoring and training. The inaugural group of scholars included 4 underrepresented minority scholars, each of whom was awarded a pilot grant and received training in grantsmanship and writing. In addition to the MAC Scholars Program, the recently funded MAC Implementation Science Hub, which is housed at Johns Hopkins University CFAR, has been instrumental in providing implementation science expertise to EHE and CFAR-funded investigators across the 3 cities. In DC, to address the diagnosis pillar of EHE, Dr. Rupali Doshi and her team are conducting qualitative data collection to understand factors associated with rapid ART initiation across multiple sectors and stakeholders. Preliminary data shown here find overall general support, but yet mixed levels of knowledge and comfort with this treatment approach. Dr. Doshi and her team intend to use these data to scale up rapid ART initiation efforts in the District of Columbia. In Baltimore City, the Getting to Zero Plus initiative has included a partnership between Johns Hopkins University School of Nursing, the Baltimore City Health Department, and various community-based partners to implement a co-located COVID-19 vaccination clinic, which also provides syringe service programs and HIV, Hep C, and syphilis testing. In just the first 2 weeks alone of this program, more than 30 naloxone trainings were provided, more than 30 STD tests conducted, and more than 60 COVID-19 vaccinations were administered. 2 people with HIV and 1 person with Hep C were identified. And importantly, the program is now able to offer immediate treatment for some STIs and immediate linkage to care for those testing positive for hepatitis C. And in Philadelphia, in relationship to the Respond pillar of the EHE initiative, in September 2018, the Philadelphia Department of Health identified a 151% increase in the number of persons who inject drugs in new diagnoses among this population. In response, they've used data-driven multi-sectoral approaches to respond to the outbreak, including increased funding for SSPs, enhanced partner services, targeted testing in key areas, and increased linkage to care activities. They've also been sharing information to community members, stakeholders, and clinical providers. Of 161 outbreak-related PWID cases, 75% have been linked to care, 51% were retained in care, and 63% were virally suppressed. Finally, I wanted to share an example of a cross-jurisdictional activity that not only includes DC and Maryland health departments, but 7 other health department jurisdictions along the Eastern Seaboard. The program is called the ATRA Black Box and was developed by researchers at Georgetown University. The program aims to identify duplicate HIV surveillance records using a secure computer algorithm. In this paper from 2019, among the 9 jurisdictions participating, over 290,000 cases matched in just 11 hours, and 3 to 51% of cases were identified in overlapping jurisdictions. This successful model is now being expanded and considered by CDC as a novel approach to routine interstate deduplication efforts, but will also importantly help us refine care continuum estimates across the jurisdictions. So in conclusion, there are many similarities in the HIV epidemics across these 3 cities with respect to demographics, risk factors, trends in diagnoses, and local responses. Significant progress has been made over the last decade in each of these 3 cities, and yet they remain some of the most severely impacted areas in the US with respect to HIV. While COVID-19 has disrupted many EHE efforts, it has also led to innovations such as telehealth and co-located services. And some of these innovations may improve our efforts to reach those most in need of HIV services. Ultimately, we're going to need multi-level, community-informed responses and cross-jurisdictional collaborations to achieve the EHE goals set forth in each of these cities. I want to thank the following individuals who provided data and slides and insights into each of their cities and helped me prepare this talk. Thank you.
Good afternoon, and thank you for the opportunity to present. Today, I'll be talking about innovative ways to meet the needs of Black and Latinx adolescents for HIV treatment and prevention. I have no conflicts of interest to disclose, but I want to let you know that I'll be presenting the work not just of myself, but of many people, including my clinical team here on the slide, and work that's been funded by many funders, including the Penn CFAR. So let's start by talking about disparities in new HIV diagnoses. Here we can see on our information from the Philadelphia Department of Public Health that the vast majority of new HIV infections in Philadelphia are among men and trans women who have sex with men. And within that group, we see a disproportionate representation of Black and Latinx individuals. What we don't see on this slide is that youth, people ages 13 to 24, make up a large and disproportionate sample of new infections as well. And this is important because we know that at every stage of the HIV care continuum, youth do worse than older adults. They're less likely to be HIV tested, less likely to be PrEP counseled or prescribed PrEP, and less likely to be retained in HIV care. And so what are some of the challenges that we see for linkage and retention from multiply marginalized youth? Well, one is that we often see there's competing healthcare needs. You may not just need HIV treatment or PrEP, you may need contraception, mental health, and gender-affirming care. And this often leads to fragmentation of care where young people need to go to multiple clinics to get the services that they need. We also have to think about the effect of intersectional stigma on the basis of race, ethnicity, gender identity, and sexuality, and how that can affect care delivery and seeking of care. We know that many of our young people have unstable housing and barriers to transportation that make just getting to the clinic challenging. And lastly, we have to think about the effects of the COVID pandemic on essential workers. I'm not thinking about just hospital workers and police officers here, but I'm thinking about people in frontline service jobs, which is the vast majority of my patient population. So I'm going to walk you through 5 strategies that we've been using to improve outcomes for Black and Latinx youth. The first strategy, go to the medical home. So we know most adolescents receive their sexual health services in primary care, but we see significant gaps in the HIV prevention pathway and significant sex, gender, and racial disparities for young people. So I'm going to talk about some of the work from my lab here at the Children's Hospital of Philadelphia, where we're looking at aggregate data from 31 primary care clinics. So we see that at the level of testing, we see racial disparities where Black females are almost twice as likely to get screened than white females for the same risk profile. And while that may seem like a good thing, it actually hints to implicit bias around sexualization of young Black women. So actually not the outcome we want. When teens get an STI, we find that only 55% of them appropriately receive HIV testing. And when we get to the stage of PrEP counseling, only 7% of teens in our cohort of thousands, over 3,000 youth with STIs, receive PrEP counseling. And then at the stage of coming back in for a repeat STI test, only 23% are rescreened, with males being 83% less likely to be screened. So how can we change this? So my K23 focuses on using this episode of STI diagnosis to link young people to HIV testing and PrEP. Thanks to funding from the CFAR, we're going to be implementing point-of-care STI testing, where we'll be using the Binks IO device to get STI results within 30 minutes, and then immediately implement culturally tailored motivational interviewing-based counseling, HIV testing, and linkage to PrEP. But we can't just have strategies in different clinics. The second strategy is go home. And I mean literally go into our patients' homes. So the COVID pandemic has brought rapid changes in telehealth. We got about 10 years of innovation in the first 10 months. And telehealth is wonderful because it's flexible to transportation and housing needs. We've been able to maintain care despite the COVID risk and exposures that have been frequent in our frontline workers. And we've also seen that it's been a boon for same-day antiretroviral therapy initiation. So from 2020 to 2021, we've partnered with our health department, and we've been able to link 21 youth with acute HIV infection to care within 48 hours of diagnosis. And many of those were able to link and start ART on the same day they had a positive HIV test through telehealth. We're also meeting our patients through telehealth on their own terms. I've gotten to meet my patients' parents, their children, their pets, and been able to better understand the context of their lives in a way that's opened up a whole new relationship with many of my patients. But it's important for us to recognize that telehealth is not perfect. There's significant issues with equity. And if you look at almost every adolescent care setting, we can see from data that Black and Latinx people have had lower rates of uptake to telehealth. So we have work to do here. It also doesn't eliminate our problem of no-shows. And in the over 300 visits in our adolescent initiative clinic for both PrEP and HIV care, we really found no significant differences in the no-show rate. So another area where some work needs to be done still. Now, strategy number 3 is actually thinking about How do we improve the clinical setting? So through partnering with public health systems, we've been working on trying to do this in a citywide level. So we have a CFAR and Philadelphia Department of Public Health Ending the HIV Epidemic partnership led by Jose Bauermeister, which has a goal of developing, implementing, and evaluating a health system intervention to inform HIV testing and PrEP uptake in young MSM and trans women, and particularly Black and Latinx young MSM and trans women. In our first phase, we did interviews with testers and agency directors to understand where the gaps and barriers were, as well as what people were doing well. We're wrapping up our second phase now of developing new trainees. And in addition to updated information on PrEP and HIV testing, we've worked in new trainings on cultural humility, on stigma reduction, and on radical customer service. And we're currently in phase 3, which is implementing these trainings and evaluating them. So stay tuned for the data on this. And I can't say enough about the importance of having affirming and integrated environments. So these are some pictures from my clinic where we do HIV treatment and PrEP for our young people. And you can see that every single one of us wears a pronoun card. So our patients don't need to be the ones who bring up the gender identity conversation. Our youth advisory board has helped us decorate some of our rooms. So you can see exam room 12 is now the ballroom with a nod to the house and ball community. When we have safer sex posters, we make sure that they represent the population that we're working with. And then throughout our hallways, you'll see artwork of people, you can see this bottom picture, who represent a variety of gender identities and represent the Black and Latinx population that we serve. And most importantly, represents those populations in resilience-focused, nurturing, positive ways. So not everything is sexualized. So strategy number 4 is to leave your comfort zone. So here you see a picture of our brand spanking new mobile health unit. And this is essentially a clinic on wheels that's been designed and programmed for youth by youth. Led by Martinez Castillo, our mobile health unit has 2 clinics in it. We'll be implementing point of care testing here. And we're also doing a lot of community events that are really led by the needs of our community. And that means instead of leading with HIV testing, our most recent event was leading with doing a clothes closet so that the youth who came to the unit could get clothes that were gender affirming and free for them. You can get HIV tested along the way, but first meeting that basic need. And strategy number 5 is to listen up. So you'll see this figure of the ladder, and this is Roger Hart's ladder of youth participation. As your eyes work up this ladder, you can see that many of the clinical programs that we work with are still on these lower rungs. And we're really working to move to a higher level where we have shared decision-making and partnership. 2 ways that we do this in our clinical model are through our Adolescent Initiative Youth Community Advisory Board that provides feedback on literally every research project that we implement. We also have a program that's being led by Nadia Daushin with funding through the Stoneleaf Foundation and the ATN to develop youth quality evaluators. So these are young trans women or female identified trans and gender nonconforming individuals who are trained to evaluate the clinics in our region. They go out as mystery shoppers and are able to feed back to us where the level of care and the quality of care needs to change. So they get to be decision makers in the process and also get vital job training as they go. So lastly, I'll just focus on a few key points where I think the research agenda does need to advance. We need better developmental pipelines for BIPOC researchers, clinicians, and staff. Involving youth as more than tokens requires paying them, and we need funding to ensure youth involvement at every stage of design. As new innovations have moved forward under COVID, we've often not been able to do foundational acceptability data, and it's time to go back to the drawing board and do that work to make sure that when programs are implemented, we're using equity as an outcome metric. And finally, we need resilience framing from a positive youth development model for minoritized youth, focusing on the intrinsic strengths and resilience of those communities. And I'd like to thank you and all of my collaborators for the opportunity to present our work, and I look forward to checking back in with you at the Q&A.
My name name is Omar Martinez, and I'm an associate professor at Temple's University College of Public Health. The title of today's talk is Implementation Science to Optimize the Use of Evidence-Based Interventions in HIV Prevention and Care Among Sexual and Gender Minority Latinxes or Latinos. Here's the snapshot of today's presentation. I'm going to first walk you through the concept of implementation science to address disparities and inequities in HIV/AIDS, followed by our work on syndemics, immigration, and stigma as drivers of the HIV epidemic among sexual and gender minority Latinos. Then I'm going to walk you through 3 selected research projects that we're currently working on, connecting Latinos en pareja, a couples-based biobehavioral intervention for Latino male couples, followed by our work on medical legal partnerships, and then wrap it up with a trans equity research project for men and women of trans experience here in Philadelphia. And at the end, we're going to have a few discussion points and takeaway. On implementation science, there has been a great push for reframing elements of implementation science to address disparities and inequities in HIV. The focus on research from the very beginning, right? The idea that we should engage community members at all the stages of the research projects, including when conceptualizing our research and coming up with the research questions. Design and select interventions for vulnerable populations with implementation science in mind. Implement what works. Develop the science of adaptation and rapid adaptation of these implementation strategies, and use equity lens for implementation. I want to highlight that this work has been championed by Dr. Cabasa, and I just want to give a big shout out for his work on this area. There's also an upcoming talk on moving anti-racism and implementation science in implementation science from the margins to the center. That's coming up November the 11th, so I highly recommend it. So a little bit of our work on syndemics. This is data from Latino men who have sex with men and women in New York City. We highlight some of these syndemic conditions and how they disproportionately impact behaviorally bisexual Latino men, from polydrug use to high stress. And what we found is that a participant with 2 or more or 3 syndemic factors were significantly more likely to be diagnosed with STIs, and participants with 2 or 3 syndemic factors were over 7 times more likely to report condomless anal intercourse than those with 0 conditions. Here's also another syndemic analysis where we look at data from sexual minority Latino men here in Philadelphia, looking at the national HIV behavioral surveillance data. What we found is that these syndemic factors matter when we look at HIV risk among sexual and gender minority Latinos. Here's the paper that was published last year, so I highly recommend for you to check it out. On immigration and HIV, our research has documented the detrimental impact of the intertwined process of immigration on health and wellness. For sexual and gender minority immigrants, anti-immigration rhetoric is often linked with HIV acquisition and transmission, delays in HIV prevention and treatment, substance use, negative mental health outcomes, and isolation. And as a qualitative researcher, I always bring the voices of those communities and those impacted. Here's one of them. Many people won't go and seek out services because they're afraid it will affect their immigration status. For fear of being found out as undocumented immigrants, they don't go and seek help. On HIV-related stigma, we published 2 years ago a paper on how HIV-related stigma is a determinant of health among sexual and gender minority populations. And important to note is that we place stigma within the concept of intersectionality, right? So intersectionality examines the juncture of multiple stigmatized identities and overlap or institutional powers that fall within or across several categories, including coexisting health conditions, experiences of incarceration and pre- and post-migration experience, and social forces and structures such as anti-immigration rhetoric and structural racism. Now, what we're doing here in Philadelphia, the first project was a CDC-funded study looking at connecting Latinos en pareja, biobehavioral risk reduction intervention for Latino male couples to improve HIV-protected acts of anal intercourse among the dyads. Important to note is that this project was led and guided by CVPR approaches, including community advisory board members, and community advisory board members guided all the stages of the research projects. And here are some pictures of our CAP meetings that led this study here in Philadelphia. And this is also the result of that CAP engaged, right? And here's a snapshot of our recruitment materials. The CAP wanted to emphasize that this was a community-based HIV prevention study. And here is the diversity of Latino male couples represented in this recruitment materials. Here's a brief snapshot of the 4-session intervention. Session 1 on personal, cultural, and contextual influence on risk and protection in couples. Session 2 on communication skills. Session 3 addressing relationship strengthening for HIV protection. And Session 4 on social support for HIV protection. Here's a snapshot of the manual and how we present this information. The prevention toolkit, going beyond condom use and using and presenting PrEP and treatment as prevention as part of this prevention toolkit. We also came up with a beautiful, well-done video that walks through the couples through these 4 biomedical prevention tools. Here's another snapshot of the actual intervention, and we embedded case scenarios that are responsive to the needs and experiences of Latino male couples. Another kudos to the CAB for coming up with these case scenarios that indeed and in fact are responsive to the lived experience of Latino male couples. The next project that we're working on is medical legal partnerships. I just wanted to highlight some of our work on medical legal partnerships. They offer a structural integrated intervention that could facilitate improvement in medical and psychosocial outcomes. And here's some of the papers that we have published on medical legal partnerships. We just wrap up the data collection for the R21, and we just got funded for the R34 to take this work to the next level. We came up with an OPAL intervention package to facilitate improvement in HIV care, continuing outcomes among those living with HIV. Here's the added value, some of the key takeaway from the added value of the attorney in the research team. They address health harming legal needs and risk. They present workshops to staff on frequent issues that arise throughout the course of their work. They present educational Know Your Rights workshops for patients and community partners. One of the also key takeaways from the R21, the study, is that what we found is that within these 8 service organizations, there's more than the HIV care continuum, right? There's also the legal continuum of care and the social service continuum of care. So this is important to keep in mind as we move forward with this line of work, right? How within these 8 service organizations, there's more than the HIV care continuum. Like I mentioned, we're now getting ready for launching the feasibility and acceptability trial. We came up with a training for providers embedded in this 8 service organizations. We're now deploying and bringing in the attorney on site to provide direct legal services to those living with HIV. So we're really, really excited about this project. Last is our project, the Trans Equity Research Project with men and women of trans experience. We wanted to develop an HIV prevention and care intervention for this population. Here's kind of like the processes for developing that intervention. Once again, community informed. We engaged community members, 20, that guided all the stages of the research process. We also engaged a scientific advisory board. We conducted in-depth interviews with peer-led navigators, men and women of trans experience leading this work here in Philadelphia. We also conducted in-depth interviews and focus group with men and women of trans experience to assess what do they want to see in this intervention. Here's kind of the end product. We came up with a 3-group-led intervention for men and women of trans experience. The first session is on self-care and comprehensive trans care. Second session is about communication and relationship building. And third session is on life skills and professional development. Key takeaways from this presentation, and I look forward to the Q&A session. First, we need to enhance the impact of implementation strategies. We need to conduct more effective research and economic evaluation of these implementation strategies. We need to promote and fund strategies for the dissemination of culturally congruent evidence-based practice, right? Thinking beyond peer-reviewed publications and really thinking about technical briefs, right? Getting this research on Twitter, on TikTok, right? On Instagram, and how would it look like? So I was honored to be part of these 2 technical briefs on promoting PrEP. The first one on promoting PrEP among PrEP continuum of care among key population in sub-Saharan Africa, and the second one on bolstering a Latinx gay and bisexual men agenda to address disparities and inequities in HIV/AIDS. When thinking about syndemics has the potential to help policy makers and program implementers in their endeavors to improve population health. We also need to improve our surveillance systems and survey instruments to better capture and understand the syndemic conditions leading to poor engagement in HIV prevention and care among sexual and gender minority Latinx population. I just wanted to highlight one of the recent paper by Ana Maria del Rio Gonzalez, Dr. Rio Gonzalez, on proposing this advanced trans center research. And I highly recommend reading this piece. We need to examine immigration as a social determinant of HIV prevention and care. Most of our work is behaviorally focused rather than investigating the contextual drivers of behaviors and the possibility for upstream change. We also need to continue the investment in the development and implementation of locally developed homegrown prevention and treatment interventions responsive of those endemic conditions impacting sexual and gender minority Latinos, including promotores de salud, safe spaces and empowerment, integrated care models, and medical legal partnerships. I just wanted to wrap it up with an acknowledgement to my mentors, collaborator, research team, and thank you for your time and look forward to the Q&A session.
Good afternoon. Today, I'm happy to share the results of a recent pilot study examining the implications of U=U belief for psychosocial and sexual well-being among MSM. The U=U message is slowly gaining traction among MSM. In a recent longitudinal study of over 100,000 US MSM, 51% of men with HIV and 19% of HIV negative men perceived the U=U message as being completely accurate. And the study found that perceived accuracy was increasing over time. There's recognized potential for U=U to enhance the psychosocial and sexual well-being of people with HIV. Thus, the aims of this study were to examine the association of U=U belief with HIV worry, sexual openness, and sexual well-being among US MSM with undetectable HIV, and to test HIV worry as a mediator of associations between U=U belief and sexual outcomes. So participants were recruited to participate in this US-based online survey study through dating apps and social media in 2019 and 2020. Eligibility criteria included being English literate, 18 years of age or older, identifying as a man or transgender man, and reporting having sex with men. Here you can see the way we operationalize belief in U=U. Essentially, anyone who believed there was zero risk of sexual transmission of HIV when the partner with HIV had undetectable HIV. Anyone who believed there was zero risk was coded as believing in U=U. Anyone who believed there was any kind of risk was coded as disbelieving. Other measures included HIV worry, so that's worry about transmitting HIV to HIV negative sexual partners. We also assessed sexual openness, so openness to having sex with an HIV negative man in a variety of scenarios combining condoms and PrEP. In addition, we examined sexual well-being. We honed in on 3 particular dimensions of well-being. That was sexual anxiety, esteem, and satisfaction. And we assessed background characteristics. For the analyses, we restricted our sample to participants who reported having HIV and also having an undetectable viral load. We conducted multivariable linear regressions to examine associations of U=U belief with HIV worry and sexual outcomes. And then we also conducted bootstrap mediation analyses to test HIV worry as a mediator of the association between U equals U belief and the various sexual outcomes. This slide provides an overview of our sample. So all participants identified as men. They ranged in age from 20 to 78 with a mean age of 45. The majority of our participants were non-Hispanic white and identified as gay. Most had at least a bachelor's degree, and over half had an income above $50,000 per year. As far as U equals U awareness, the vast majority had previously heard of U equals U. When it came to actual belief in U equals U, as we operationalized it, 68% believed in U equals U. Here are our various regression models examining U equals U belief in association with HIV worry and sexual openness. The association with HIV worry was significant. The association with sexual openness was not statistically significant for any of the 4 combinations of PrEP and condoms that we examined, but it was marginally significant with openness to sex with an HIV negative man without PrEP and without condoms. U equals U belief was not significantly associated with any of the dimensions of sexual well-being that we looked at. Here you can see our significant mediation models. So we did find significant indirect effects such that U equals U belief was associated with reduced HIV worry, which in turn was associated with greater openness to sex with a HIV negative man without PrEP and without condoms, greater sexual esteem, and greater sexual satisfaction. To summarize, belief in U equals U was directly associated with less HIV worry and indirectly associated with more sexual openness, esteem, and satisfaction. Interventions that increase understanding and perceived credibility of U equals U may be psychologically and sexually empowering for people with HIV. In closing, I just want to thank the study participants, my research team, and GW for the funding for participant incentives, and also leave you with my contact information. Please feel free to reach out with any questions. Thank you very much for your attention.
Thanks for this great session, a great series of talks, some really important information. I'm Dave Metzger from the Penn CFAR, and we have a few minutes for questions. I know there are none that have appeared online, but I'd like to start the conversation by asking our speakers to get their opinion on the impact of the COVID pandemic has accelerated the use of technology for telehealth, for recruitment strategies, for interventions. And I'm just wondering, and your talks have touched upon these new strategies and for engaging individuals who are living with HIV or at risk for HIV. But I'm wondering if your thoughts on, are we making headway in getting at the population of folks who are currently not connected to HIV care or to prevention strategies? I guess my question is, are we making an impact on the challenges of that we've been facing for the last 10 years in terms of reducing new infections and engaging more people into care?
I can start. As I was preparing the talk and really looking at the EHE strategies across the 3 cities, it really was impressive how innovative people's approaches have been, which many of them really did include not only community-informed approaches, but also some aspect of technology. And as I alluded to in the talk, I really do think that the pandemic has somewhat forced us to think even more creatively about how we can more rapidly scale up some of those approaches and interventions using telehealth, using mHealth, and that it won't only be during the pandemic, but that hopefully these will be some long-lasting approaches that can help us engage or retain or re-engage individuals who we may have lost kind of along the care continuum, and that these approaches may help facilitate getting those individuals back into care and getting them back to the services that they need to access.
I just want to also say, now this is from a community advisory board perspective. What we did as a CAB was we went and got tablets and iPads so that all of our members could still be connected during COVID, which we thought was a great thing. We had our administrator, Amy Honorado, who was teaching them, folks who don't usually have access to those types of things. She taught them how to use them. But another thing we did was we became educated. As a CAB, we asked questions and had some of the doctors from Penn come to us and talk to us about COVID. We asked questions about COVID and HIV. So again, for the Community Advisory Board, it's another learning tool. Give us the science and we'll take that information into our communities.
Great. Thank you to both of you. I have a question, and I think this is really for all the panelists. And so, although this question is inspired by Daiquiri's presentation, and that is, it seems very clear that all of you have engaged community in planning your different studies and research projects. And I'm wondering how you've actually or either plan or have disseminated the results of your work to the greater community.
Just briefly for the CFAR CAB, Penn CFAR CAB, what usually happens is that anyone who's doing any type of research, they ask to be invited so they can let us know what they're doing in the community. They may bring a research protocol to us to read over. They may bring some of their flyers that they're going to be putting into the community. And what we do is we give them honest critique on whether or not this is going to be something that's going to be viable in the community. We may even ask them what is the grade level of the language in those flyers. And then some have come to us and said, we really didn't engage community like we should have. And can you tell us what to do? And then we give them the steps that they need to take. And then they do come back with information about how they're doing in their study. And then from there, we go out and let people know this is what they came to us with, this is what we helped them with, and this is what they and these are the results of it. So we try to do the best we can to get it out as soon as we can once we know, because we know it takes years to really get things done when it comes to research.
Excellent question, Dr. Brady. And I'm sorry, I scanned through the slides really quick and couldn't go and dive into the couples-based HIV prevention intervention that we developed and we conducted here in Philadelphia. And one of the unique components of that study was the active engagement of our community advisory board. We conducted a total of 10 CAP meetings in 4 years. And that was a constant communication and bi-directional relationship with that CAB. And while we were conducting the study, we were sharing back the data that we were collecting. For example, from the screening instruments that we conducted, 56% of the sample reported childhood sexual abuse. So we took that data back to the CAB, right, for them to analyze and really add nuances of why this high prevalence estimates of childhood sexual abuse among sexual and gender minority Latinos in the city. So once again, that ongoing process and communication with the CAP is essential. Other speakers have highlighted, we usually bring the CAP at the end and pay them $50. No, active engagement and true CVPR require active engagement of that CAP throughout the research process, and that bi-directional relationship, sharing back the data that is resulting from the study. Another piece is that we have been really successful in establishing a social media platform. We have Twitter accounts, Facebook accounts, Instagram account, with more than 10,000 followers thus far. And we not only share study-related material and information, we share about community health, we share about job training initiatives. So it was that constant feedback and engagement to these social media channels as well. So just wanted to add those two pieces.
And I can add from the overall DC CFAR perspective that we are intentional about engaging our community stakeholders. We have a community partnership council. They've rebranded themselves from being named a CAB. They're involved in review of concepts, of pilot awards. So again, as Omar was saying, from the beginning, and we also have opportunities to disseminate information back to them from the research that we've done. I don't know if Dr. Calabrese wants to talk about her work, but we certainly have different CABs for different studies, and we make sure that we do disseminate information that it's digestible to our CAB members, right? That we are cognizant of health literacy and translating what are sometimes very complicated scientific findings into language that can be understood by everyone. And so for my study, the DC cohort study that I run, we have the CAB involved in everything from our recruitment materials to the newsletter that goes back out to let them know what's happening with the study.
Right. I think we've reached the end of our question and answer period. I know there are a couple of questions in the box, one for Sarah Wood and one for Sarah Calabrese. So maybe you could plan on answering those by
Actually,
text.
Dave, we got permission to go to 3:20.
Oh.
So, yep, there's a time update. So we can go ahead and ask those questions.
Okay, great. Do you want to read it?
Yeah, sure. Sure. For Sarah, thank you for the wonderful presentation. This is from Michael Carfin. He wants to know if there was any reluctance by young people to use a mobile van that is branded as a health van.
Yeah, I think that's a great question. And we may sound a little bit like a broken record, but again, I'll say that having our community advisory board of youth involved from the very early stages has helped us make sure that we've branded this in a way that is broadly inclusive and really thinks beyond health. And actually, so far when we've taken the mobile unit out, really we haven't used it for health purposes. Our youth community advisory board has been really instrumental in pulling together events. So one of our first events was partnered with a youth transitional housing program, and it was a clothes closet because what the teens really wanted wasn't HIV testing and STI testing. They wanted gender affirming clothes. So we brought clothes, and then it's sort of like, if the clothes are what get people in the door to be able to engage in doing HIV or STI testing, that's great. But if we don't think about those sort of key social determinants when we're programming for youth, particularly youth who might be living really on the margins of access to a lot of services, then we're not really meeting what their needs are. Similarly, I didn't get to talk much about the way that the mobile van looks. And this is really all the brainchild of Marne Castillo, who is the person who's been really instrumental, and Maddie Lehman, in getting our mobile unit together. But there was actually a contest that the young people on our YCAP held to identify an artist, and they had to basically the artist had to present and bring a charrette and come up with the design. So it was every element of it has been really designed to be youth focused and youth informed. And I think that's really going to help a lot in terms of, it may not be HIV testing that gets people in the door, but once people are in the door, then they're going to be able to access those services.
Thanks, Sarah. I think that also highlights really the importance of getting that CAB input to know what the community is interested in.
I see there's another question for Sarah Calabrese, who also gets a shout out for a great presentation. Did you learn, or how much did you think that internalized stigma might affect the connection between U equals U belief and sexual openness and wellness?
Thanks for the question and the shout out. It's a good question. I think that we think about U equals U belief as potentially having this effect on stigma, right? That if you believe in U equals U, that will reduce internalized stigma, it'll reduce other aspects of stigma. And so with respect to the presentation you just saw, I could see where it might function as a mediator. That being said, in some of the analyses we've done with the same data set, we actually didn't see a significant association between U equals U belief and internalized stigma among people with HIV, so we looked at a number of different dimensions of stigma among men with HIV as well as HIV negative men. We had a separate sample of them as well. And where we really saw the association between U equals U belief and stigma was among the HIV negative men. And we didn't see a significant association among the men with HIV.
So actually, Sarah, I just want to follow up with you with another question. We talked a little bit about this yesterday in the poster session, but you know, your study population was predominantly white. And, you know, I had some concerns that there could be some racial ethnic differences, but given the size of the sample, it's probably too difficult to really see any significant differences. If you had to do your project all over again, what would you do differently potentially in terms of trying to engage a more racially ethnic diverse MSM population?
Yeah, that's a good question. And thank you for raising this both today and yesterday. So yeah, it was a small sample and we primarily recruited through a single dating app. And so the majority of the sample was white. The number of people of color was smaller. I did look back at the data after our conversation yesterday. There was not a significant association between, or a significant difference between white men and men of color in terms of U equals U belief, but it was such a small sample that I couldn't really parse apart individual races. So to get to your question about what I would do differently, I mean, I think the theme of this session has really been the importance of engaging community. And with this study, it was kind of a quick pilot study we did in partnership with Hornet, and we didn't engage the community as much as we could have. So I think if I were to redo this, I would consult with the Community Advisory Board, or I guess they've been renamed, but the community folks with the DC CFAR, and really think about kind of how we might recruit a more diverse sample, as well as what other questions we might ask. One of the things that came up in my session yesterday was just about how U equals U belief might impact disclosure to partners, for example, which is a really fascinating question and not something that we asked in this study. And so I think that, questions like that could have come up if we had had an earlier consultation with community members. So that's what I would do differently. It's definitely a limitation of the study.
Okay, thank you.
Oh, I was just going to say, I see we have one more question. Probably
okay.
Time for a question directed at Omar, and this is from Ron Coleman, who wants to know how you balance your role as an implementation scientist with your role as implementer of programs.
Yeah, I think that's a great question that we all struggle with, and I've been fortunate to receive funding and ensure that we have a robust research team. I have a project director for each of these projects. I have a CAP, a community advisory board. I have research assistants embedded as part of that process. The CAP, once again, so when I get this data back, right, there's a robust qualitative methodology to really analyze that data. Independent coders, including community members, coding that data, being taught on how to code that data and analyze that data. So I have integrated that check and balances, right, to ensure that my subjectivity and my passion, it comes across clearly, doesn't get into the way on how we analyze this data and how we look at these implementation processes. So ensuring a diverse research team with diverse perspectives, right? Ensuring active CAP engagement. We also have a bunch of students analyzing that data, being part of the analysis processes. So all of these factors help in those endeavors.
That's great. I think we're out of time now. Kathleen, is that correct?
Yeah, I think we have, unless any closing comments from folks at this point in time? Well, I want to thank everyone. Yeah,
say
go
again,
ahead.
what a great panel this has been. And thank you all for your presentations. They were really informative and helpful and well done.
Thank you. I just wish we had more time. All right. Well, thank you very much. And we'll see. I just need to remind everybody, we will be having Rochelle Walensky at 3:25. So please join for that session. Thank you very much.
Thanks, everyone.
Thank you.